Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. Today, I'm going to share with you two interesting cases of metastatic carcinoma to the stomach. Now, we know that the stomach is usually the site that sends out metastasis, sometimes presenting as carcinoma of unknown primary. But in this instance, in the two cases that I'm going to share with you, actually what happened is quite the opposite. So the first one is for a 63-year-old female patient who is known to have a breast carcinoma. And this is a very important clue that we should always keep in mind. History is extremely important whenever we encounter and report any pathology, actually, any pathology biopsy. So she presented with upper gastrointestinal bleeding and recurrent vomiting. And this is the endoscopic biopsy, one of the fragments. What was mentioned actually in the endoscopy that the mucosa looked unhealthy and very friable. And in this fragment, in this biopsy, you can see ugly looking tumor cells with perhaps lymphatic permeation here, and on higher magnification, again, groups of tumor cells, some with signet ring appearance and lymphatics. And this is an extremely important clue that should alert us to the possibility of metastatic carcinoma. Again, on higher power, really what looks like signet ring carcinoma, a hyperchromatic nuclei to one side, lumina containing intracytoplasmic mucin. So really what would come to mind is poorly cohesive carcinoma of the stomach. But remember, the patient has breast carcinoma, and then we have lymphatic permeation. This fragment was at large composed of benign gastric tissue, but with one focus of lymphatic invasion, and a third fragment with several foci of lymphatic permeation. These should be good clue that we might be dealing with metastatic secondary rather than a primary carcinoma. And all you need to do is one stain. GATA3 was strongly positive in the tumor cells, the individual tumor cells in the mucosa, and the tumor cells forming groups within the lymphatics. So the final diagnosis on this case was metastatic carcinoma to the stomach. Another rare representation is metastatic ovarian carcinoma to the stomach. And this is a case of a 51-year-old female patient who's known to have metastatic ovarian carcinoma to the peritoneum. She presented with intractable vomiting and again, gastric biopsy with the groups of tumor cells. Now, if you don't know the history, you might think, okay, this is probably primary gastric carcinoma. Even if you know the history, ovarian cancer are very rare to metastasize to the stomach, and we have really to actively rule out metastatic versus primary. And there is the immunohistochemistry. PAX8 is positive in the tumor cells, while MUC5 as well as CDX2 are completely negative. So the final diagnosis on this case was metastatic ovarian carcinoma to the stomach. So the message from today's two cases is that history is extremely important. Knowing what the patient has prior diagnosis helps a lot in sorting out some unusual presentations, like both cases, metastatic carcinomas to the stomach. And we should always keep this in mind, especially when we encounter any unusual morphological features, like the first case, the presence of what I would consider to be extensive lymphatic permeation should be a good clue that this is probably is metastatic rather than a primary carcinoma. I hope you find this tip useful in your daily practice. Thank you.